Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice case that should always alert us to think probably outside the box. This is a case of diffuse midline glioma with bone metastasis. So this is a 19-year-old male patient who started to complain of recurrent attacks of headache, became more severe, accompanied by right-sided weakness and aphasia. He underwent brain and spine MRI, which showed conus medullaris lesion that was suspicious for spinal glioma with diffuse leptomeningeal enhancement consistent with diffuse leptomeningeal metastasis and several osseous metastasis. Now, one of the metastases affected the iliac bone, and so a bone biopsy was obtained from the iliac bone. And this is the low power magnification of the iliac bone biopsy. This is the normal hematopoietic elements from one side and the other side. And then there is this area which is hypocellular, and on higher magnification, it really shows this aggregates or groups of tumor cells growing in an acidophilic fibrillary background, showing this amount of pleomorphism, and on higher power magnification, more pleomorphism. This fibrillarity in the background should be an excellent clue to a possibility of diagnosis of a glioneuronal tumor in general, for which we should apply the proper immunohistochemical stain. So this really, the clue to perhaps the diagnosis, I would say, came from the fibrillarity that is seen in the background, in addition to the presence of the malignant tumor cells, of course, in correlation with radiology. And GFAP was strongly diffusely positive in the tumor cells, in the fibrillary background, as well as in the cytoplasm of the tumor cells. Really robust GFAP immunohistochemical staining in the presence of internal negative control. Remember that you should always make sure that, especially with the strong stains, that you're not over staining, and that what you're seeing is a real reflection of the real positivity of the tumor, rather than overexpression or over staining. And then OLEG2, beautifully positive in nuclear stain. Both GFAP and OLEG2 together would support that this is a glial tumor. Now, synaptophysin was also positive. Remember that in general, diffuse midline gliomas can be positive for synaptophysin, and even they can be negative for GFAP. So this might sway you away from the diagnosis, but remember that synaptophysin can be positive in diffuse midline glioma. Now, one other tip always to remember, that pancytokeratins, especially the AE1, E3, can be positive in gliomas, in GBM, beautifully positive, like in this case. And the idea is that pancytokeratin is an intermediate filament similar to GFAP, and there is some tendency for a cross-reactivity between the different intermediate filament antibodies. Because of that, pancytokeratin can be certainly explained in this context by the cross-reactivity. If we want to be sure that this is not a carcinoma, we have to specify, try to choose another type of cytokeratin, preferably CAM5.2, and not the pancytokeratin. Usually the AE1, E3 would stain similar actually to GFAP staining. Now, this here comes the clue or the support to the diagnosis. The H3 K27M stain shows nuclear positivity consistent with a mutant, with the mutation and with abnormal expression. Now, the H3 K27M E3 usually shows loss of the nuclear stain, but sometimes, especially outside the brainstem, outside the pons, can show attenuation rather than complete loss of the nuclear stain. And so we can see that there are some nuclei which are negative, but in general, there is attenuated nuclear positivity, which means that there are low levels perhaps of expression of the stain. However, if we put the H3 K27M versus the trimethylated H3 K27ME together for comparison, the capital M immunohistochemistry carries a significantly more weight than the H3 K27ME. Now, P53 is usually positive in these tumors, thus the whole picture together in correlation with the clinical findings would be consistent with the diagnosis. Of course, there has been a large number of immunohistochemical panel applied to the case just to make sure that nothing is uncovered. For example, there's not hematopoietic disorder. This is not a germ cell tumor. This is not, for example, especially with the pancytokeratin expression and atypical teratoid rhabdoid tumor too. So to wrap up, this case is a case of a young male patient who had a spinal lesion with bone with metastasis, with H&E images or findings with fibrillary in the background, the strong GFAP positivity, the positive or a mutant H3 K27M staining in the presence of attenuated trimethylated H3 K27 and then positive P53. Put all together, this would be consistent with the diagnosis of diffuse midline glioma metastasizing to bone. Actually, bone is the single most common site of metastasis of high-grade gliomas, glioblastomas in particular, in general, and this important differential diagnosis should always be kept in mind. Remember to correlate with radiology. Really pay attention to the H&E findings because the clue almost always lies within the H&E slide, and from here you can actually build up your immunohistochemistry. Remember that the potential pitfall of pancytokeratin positivity and cross-reactivity of all intermediate filaments in general, causing some confusion in the diagnosis. I hope you find this to be useful in your daily practice. Thank you.